the simplicity of the respiratory system. And I mean, there's some hard concepts in this, but really the job or the responsibility of the respiratory system is to transport oxygen to tissues that need it and to basically pick up the garbage, the cellular waste of the respiratory gases, which is carbon dioxide, away from the tissues and get rid of it, okay? So again, we're going to see that occur, all right, between the atmosphere, that includes like this environment, being here in this room, all right, and the cells of our body, our systemic cells, all right? Now, we all know the importance of oxygen, all right? That's the gatekeeper into the mitochondria. We need oxygen. Remember, we can't, and we'll talk a little bit more about metabolism. That's going to be in one of the last topics that we will cover in this class, is going to be cellular respiration, a little bit more detail. Up until this point, you just know that you need oxygen for the mitochondria to make ATP, and we'll kind of go through the steps of that later on. All right. So think of it, it is the gatekeeper to get pyruvate, excuse me, into the mitochondria. Okay. So it's like having that friend that knows the bouncer and then get you into the club. All right. That's what oxygen does. It gets you into the club. So now we can, instead of just generating 2 molecules of ATP per 1 molecule of glucose, now we can generate 32 molecules of ATP per 1 molecule of glucose. All right? So it's huge. We need it for energy. Okay? And as, of course, as you know, also when we have cells that are undergoing metabolism and doing things, there's going to be waste. Right? We see it in our own bodies. Well, the cells are no different. And the waste version of the respiratory gases are going to be carbon dioxide. Okay? So we're going to start off talking about gas exchange, how we're going to get the gases from the atmosphere into our blood and the gases from the blood back into the atmosphere. All right? So last week we talked about, all right, pretty much the respiratory system. We have a pretty decent understanding of that whole conducting, all right, and respiratory areas there of the head, neck. We include the trunk, basically where the trachea and the bronchioles are, down into the lungs there, all the way down to the alveoli. So we'll discuss all that. We discussed more of the anatomy in lab, which is pretty much what lab is for, but now we're going to get into the physiology. So we got to go over a couple terms here. So have you ever wondered why you don't walk around with your lungs collapsing on themselves? Well, we're going to talk about that. All right, because that has to do with pressures inside the lungs, all right, and some chemicals, okay, mainly surfactant. All right, so the first pressure that you need to be familiar with is this term here, intrapleural pressure. Okay, remember when we talked about way back in chapter 1 and 210, and we mentioned it a little bit here this semester in 211, we talked about the different types of membranes. Okay, 4 different membranes: the serous membrane, cutaneous membrane, synovial membrane, and the mucous membrane. All right, well, the serous membrane, okay, a serous membrane is a membrane that you find that lines body cavities. Well, the lungs are no different. They reside in the thoracic cavity, but specifically in the pleural cavity, okay? So when we're dealing with the pleural cavity and the serous membranes, there's 2 layers, okay? The visceral layer directly lines the organ itself, so it'll directly line the lungs, and then the parietal layer lines the cavity in which the lungs reside in, okay? Well, guess what? You have a pressure in between those 2 layers, okay? That's why, hence, intra, between, all right, the pleura. The pleura is the visceral and parietal pleura, okay? Keep in mind, this pressure is very low, because we're going to talk about, remember how important the whole pressure gradient concept was when we were learning about the heart, okay, when blood flows from an area of high pressure to an area of low pressure. All right, we're going to see that the flow of air is going to be very similar. Okay, we call that the pressure gradient. It's going to move down the pressure gradient. So we're going to talk about that. Okay, so the intrapleural pressure, okay, is going to be low. All right, and this allows and helps the lungs to expand outward. Also, in between those 2 layers, the serous membranes, all right, the visceral and the parietal layers, remember we talked about surfactant, all right, if you remember from your 210 experience there, surfactant gets secreted in between those two layers, right? And it helps to keep the lungs inflated there. Did I say surfactant? X that out. It's not surfactant. Surfactant is secreted, I'm jumping way ahead, it is secreted by the type 2 cells, okay? Different, but in between the two layers, it secretes a lubricant, serous fluid, okay? Serous fluid. And that serous fluid helps. If you've ever done this before, you can experiment. You can get your hands wet and push your two hands together. You can make a suctioning type of sensation there. When there's water there, because of the physical properties of water, it helps to increase that suctioning. And that's what we see here. That serous fluid is going to create a suctioning type of property in between the two layers there, and it helps to create this tension to expand the lungs outward. So you have, here's your lung cavity here, all right, the intrapleural pressure, and because of that serous fluid there, helps to expand the lungs outward. Meanwhile, it's battling elastic tissue. Okay, it's like taking the elastic band on your underwear or whatever and pulling it out. When you release it, it snaps back. Well, you have an inward pressure or pull of the elastic tissue. We saw that on all the alveoli there. Remember those little black lines that we saw lining all the alveoli? Because as you inflate, they get bigger, but then they'll spring back to their original shape. And that's because of the elastic tissue there. Well, that elastic tissue is going to be pulling the lungs inward. Okay? So you got the surface tension between the two membranes there of the visceral and parietal layers that pull the lungs outward. That's one of them. And then you've got the elastic tissue that's trying to pull the lungs inward. Okay? So keep in mind, all that, the reason I'm trying to explain this to you is because the intrapleural pressure is low. Keep that in mind. Okay? We have another pressure, the intrapulmonary pressure. This is basically going to be in the lungs, specifically in the alveoli. Okay? You need to know this relationship. This pressure is greater than the intrapleural pressure. And because of this fact that the intrapulmonary pressure is greater, all right, this helps to maintain the lungs' patency, or it keeps them inflated. So the overall outward pull on the chest wall keeps the lungs from collapsing in on themselves or inflated. Okay? So the intrapulmonary pressure is pushing outwards. Okay? In addition, all right, in addition to the serous fluid surface tension, all right, that is going to be pulling the lungs outwards. Okay? All that helps to keep your lungs inflated here. So let's zoom in here on this slide here. You can kind of see what we've done. All right, we've taken a little section, all right, of the lung. You can see here's the lung tissue. This is where your intrapulmonary pressure is, where the alveoli are. Then you got this two-layer membrane here. All right, the one that lines directly on the surface of the lung is the visceral pleura. And then we got this little space here. And then the other side, we've got the parietal pleura. And in between here is where, all right, that serous fluid is going to be located. And then outside of that, you've got the intrapleural pressure. So the intrapleural pressure is pulling the lungs outward. The intrapulmonary pressure is also going to pull the lungs outwards. But then we have a really small force, the elastic tissue on the inside of the alveoli, that are going to try to pull the lungs inward. But they can't beat those other pressures. Okay, so that's why our lungs stay inflated. Okay, so that's inflation of the lungs. Now I want to talk about how we are going to move air throughout the pulmonary system, not including the circulation, just the breathing passageways here. Okay, and it's based on it's basic, real basic stuff here. Okay, so when we talk about respiration, all right, we're going to talk about the exchange of those gases, all right, between the atmosphere, air outside, air in this room, whatever that air is immediately outside of your body. Okay, that's going to be our atmosphere, all right, and the cells of our body. So there's 4 processes that go on. Okay, so the first one we're going to talk about is the pulmonary ventilation. Okay, how are we able to move air that's in this room into our lungs? All right, and then how do we move the air that's into our lungs back out into this room? Okay, so we're going to spend a good period of time talking about that. All right, now the air that we bring into our lungs, we refer to that as the alveolar gas exchange or the external respiration. Okay, how do we get those external respiratory gases to cross over into our circulation? Okay, what happens between the pulmonary capillaries and the alveoli? All right, then we've got gas transport. How do we then, once it's in the blood, how do we move it through our blood, all right, and then eventually wind up getting it to the tissues that need it, all right, which is our systemic gas exchanger, also known as internal respiration. And how do we exchange those gases that are in the blood with the tissues? And how the tissues then are able to exchange the gases, all right, that they no longer need, like carbon dioxide, back into the blood. So we're going to talk about all that. All right, not today, all right, but throughout this chapter. Okay? So we breathe air into our lungs. That air is then going to diffuse into our circulatory system, the pulmonary circulatory system. Then it's going to get transported throughout the systemic circulation, and then it's going to head towards the tissues. And then those gases are going to move from the blood into the tissues. Meanwhile, you'll have gases that are going to move from the tissues back into the blood and then circulate back into the lungs. Okay, so we're going to talk about all that. All right, all four of those. So this next slide is a real basic overview, all right, of that process, of what I'm telling you here, in a step-by-step, 8-step storyline. Okay, so the air from the atmosphere is going to enter into your lungs, all right, as you take a breath. There's 2 phases to respiration. The first phase, all right, is going to be inspiration, taking a breath in, okay? As the air enters into your lungs, all right, then that oxygen is going to cross over from the lungs, from the alveoli, into the pulmonary capillaries, okay? From there, it's going to circulate throughout your body, and it's going to eventually wind up in the systemic cells, your body tissues there. And it's going to go, all right, from the blood into the body tissues. So it is going to diffuse. That's going to be the term that we use for the movement of oxygen across the capillary, all right, endothelium, and into whatever tissue that we're discussing, okay? And it's going to head into those systemic cells there, all right? At the end of that process, all right, we are then going to take the waste gas of carbon dioxide. It's going to leave the systemic cells and then enter into the blood. And then it's going to then travel through your systemic circulation and eventually wind up in the lungs. And then it's going to diffuse from the pulmonary capillaries into the alveoli. And then you are going to breathe it off as you exhale back into the atmosphere. That's it. That's the story that we're going to tell, this whole chapter. Now, if you were to walk away from that slide right now, I think that every single person in this room, including myself, would feel pretty good about that. Like, that seems easy. I wish we were only that easy. All right, but but you see what I'm saying? Keep it that simple. All right, we were going to talk about some of the concepts that are going to involve the movement of these gases. All right, and believe it or not, a lot of you already know this stuff. Okay, so we're going to get into some fun properties of physics. All right, I know. Yeah, we're going to get into Boyle's law, which is a cool property. I really love it. And then we're going to talk about flow again. You remember when we were talking about flow for the bloodstream? All right, the flow of blood, all right, is equal to the difference in the pressure gradients divided by resistance. And we're going to talk about all that. So it'll come back to you. Trust me. Some of this stuff you're going to already know. Okay? So it really won't be anything that's too new for you in your understanding of this material here. Okay? KISS principle. Keep it simple. And that's what I'm going to do. I'm going to keep it as simple as possible for you. All right? So this slide here, all right, or slide 7, is represented in your book on this page here, on 2318. Figure 2318 basically shows in picture form what I just said. Okay? Air enters into the lungs, okay, diffuses from the lungs and the alveoli into the pulmonary capillaries, moves into your systemic circulation, moves throughout the body. Then it goes to the systemic cells where the oxygen diffuses off into the cells. Meanwhile, at the end of our capillary bed, all right, carbon dioxide diffuses from the systemic cells into, all right, the venous drainage there, all right, and then it circulates back, all right, to the pulmonary circulation into the lungs, all right, and then carbon dioxide diffuses across the capillaries back into the alveoli, and as you exhale, you breathe out the carbon dioxide back into the atmosphere. That's simple. That's simple. Okay? So we're going to start off with this first, all right, process here. We're going to start off by talking about pulmonary ventilation. So the movement of gases between the atmosphere and the alveoli. We're going to learn how that works, okay? So to understand that, we've got to learn or go over a few concepts. First is, all right, breathing involves 2 cycles. Easy. 2 phases, excuse me, not 2 cycles, 2 phases, okay? Taking a breath in, taking a breath out. That's it, okay? Inspiration, all right, and expiration. Inhale, exhale, okay? So right now, all of us, as we're sitting in this room, we're undergoing eupnea. Okay, eupnea is normal breathing while at rest. We all should be doing that, hopefully. Okay, and normally, if we record that, your respiration rate, it should be about 12 to 15 breaths. I've seen it in some literature up to 12 to 18 is the normal eupnic, all right, respiratory rate for someone at rest. Okay, so roughly about 12. Your book says 12 to 15, so we'll go with what the book says. Okay, so 12 to 15. Now, in certain situations, you may have to undergo an increased rate of respiration or an increased force of respiration, depending on what you're doing, all right, or depending if you have a certain condition. Okay, so if you're exercising, obviously, your metabolism is going to increase. More tissues are going to require oxygen, so your respiration rate will increase, and the force of your breathing will increase. Okay, so we call that forced breathing. Okay, forced breathing will occur depending on what the demands of the tissues are in your body. Okay, and in some cases, forced breathing occurs, all right, to actually, because you might have pulmonary fibrosis, emphysema. Someone like myself who has asthma, okay, may have to undergo forced breathing just to sustain normal cellular metabolism. Because remember, the whole point of not the whole point, but a big part of respiration is to supply our cells with oxygen so they can make that ATP and so they can make a lot of it. Okay, we need to do that. All right, so when you briefly, hopefully in chapter 13, when you went over the brain, your instructor went over the brain stem, one of the coolest parts of the brain. Remember, your brain has 4 parts: the cerebrum, the cerebellum, the brain stem, and the diencephalon. Well, the brain stem has 3 components to it. Okay, it's got the midbrain, the pons, and the medulla oblongata. Well, in the medulla oblongata, you have your autonomic nuclei. And these autonomic nuclei are going to regulate your breathing rate. We'll talk about them in a little bit. There's also a center in your pons, right, that also helps to regulate your breathing. Okay, actually, it helps to regulate the transition for smooth breathing between inhalation and exhalation. Okay, and we'll talk about that later on. All right, so what do we need to breathe? Okay, well, you need some lungs that are working pretty well, okay, but you need muscles. Remember, muscles equal movement, so you need skeletal muscles. Remember, when you see skeletal muscles, you should be thinking voluntary control, and you do. You have voluntary control, and in fact, last class in the lab, we talked about all these skeletal muscles that are involved in breathing, and we talked about some of the skeletal muscles that are involved in forced breathing, okay, and we'll review those quickly here. All right, but basically, the whole point of these skeletal muscles is that they're going to change the thoracic cavity's size and shape. Basically, it's going to increase and decrease the volume of your thoracic cavity. Okay? So when you take a breath in, you make the thoracic cavity bigger. And then when you are breathing out, you make that thoracic cavity smaller, or it returns back to its original shape. So breath in, you're making everything big, and then as you breathe out, everything shrinks back to its original shape. That's what we're talking about here, okay? So we're going to talk about how volume, all right, and pressure, all right, are going to play a role in affecting the other, all right? Boyle's law. We'll talk about it. I love it, okay? But you heard me mention earlier, right, that we're going to deal with pressure again, and that pressure gradient. Well, we know it already from when we were talking about fluid pressure gradients when we were talking about the heart. Okay? Well, air is going to be the same. It's going to move from an area of high pressure to low pressure. Awesome. I don't have to memorize something new again. I love it when I get to recycle old stuff. Okay, now I can free my brain up for learning new stuff. Okay, so we already know this concept. Okay, so we learned in the heart that blood, a fluid, is going to move from an area of high pressure to low pressure. And what we're going to see here with air is that it's going to move from an area of high air pressure to low air pressure. And that's going to occur, we'll talk about it, during the phases of inspiration and expiration. Okay, we'll get to the specifics there. Okay, so let's let our brains relax for a few moments and do a quick review on all the muscles, all right, or most of the muscles that play a role in this, because you should know this stuff. Okay, so let's talk about muscles for breathing. These two are very important, diaphragm and the external intercostals. So as you're all sitting here and as I'm sitting here, all right, we're all breathing and using these muscles. So when you take a breath in, inspiration, you need to know this is what happens. The diaphragm, all right, when you're not breathing, when you just let out a breath, your diaphragm looks like this, like a dome. Okay. Then when you take a breath in, okay, it flattens. It goes down. Okay. So during inspiration, the diaphragm will contract. As it does so, it flattens out. Okay. Meanwhile, as that's occurring, the external intercostals are going to lift the ribs up like a bucket handle. You heard me say this last time. Okay. So for those of you, I hope you know what I'm talking about. When you're picking up a bucket that has a handle on it, all right, when you lift it up from the side, they move up and out. That's what we talk about with the bucket handle. So your ribs are going to elevate up and out. Okay. So then for exhalation, when you breathe out, as everything is relaxing, the opposite occurs. Okay. So when you relax, all right, as you exhale, the diaphragm goes back into that dome-like position there. All right. And then the external intercostals, they relax, they lower the ribs back down. Okay? So those are the two muscles that you are going to be using as long as you're a healthy individual. All right, as we're all sitting in this room, we're going to be using our diaphragm and our external intercostals. Breathing in and then breathing out. Eupnea. Okay. So what happens when I have to force a breath? Take a deep breath. All right, now I'm going to be recruiting some other muscles. Okay, and then as luck would have it, all these muscles are located superiorly on the thoracic cavity. I should say on the cavity, but on the thoracic rib cage there. Okay, so sternocleidoid mastoid and the scalenes, that's going to be up by the head and neck. All right, they're going to affect, all right, the sternum. And they're also going to affect the first and second ribs, help to elevate them and move them up and out. Pectoralis minor is going to help to move ribs 2 through 6, all right, on the anterior portion of your rib cage, helps to pull that up, okay? And then serratus posterior is going to also lift you up and out. Well, quick review here. We saw this picture. I love pictures. So all these are pointing here, okay? Here's sternocleidoid mastoid and your scalene muscles. They're going to lift the first and second ribs. All these are, again, above the thorax. Here's pectoralis minor. Again, it's going to help lift up these upper ribs here. Okay, and then we go on to the back. All right, here is serratus posterior superior. All right, and it's going to help to elevate the ribs here. All right, on the superior portion of the thorax here. So all of those, oh, and I can't forget erector spinae. All right, erector spinae, the deepest muscles here. All right, they're going to run along the posterior aspect of the ribs, and those two, all right, will be involved. All right. Wait, scratch erector spinae. That's going to be for exhaling. All right. Wait, where am I? Wait, hold on. I skipped. Okay, no. My bad. Keep erector spinae. That's going to be for inhalation. I was on the wrong slide. Okay, So keep in mind, that's for forced inspiration, taking that deep breath in. Now, there's going to be situations in which, not when you're necessarily exercising, okay, but there's going to be folks that are going to have issues, all right, with normal breathing. Perfect example, emphysema, okay? So emphysema is going to, we're going to see conditions in which people are going to have difficulty breathing, and they can't, and just the diaphragm and the external intercostals are not enough. So they will have to recruit certain muscles of expiration, or excuse me, of inspiration to help get that breath in. All right, asthmatics usually have an issue with exhaling more because of the resistance that they encounter in the bronchioles. So you'll see that they'll have their muscles of expiration are a little bit better designed, or not designed, developed. All right, and they might have to recruit those a little bit more often. Okay, so when we see, all right, the thoracic cavity increase in volume, we are going to see the rib cage move upwards. You're going to see it expand laterally. Okay, so you're going to get wider. All right, and then also you'll see it increase front and back. The sternum will lift forward there. All of that is going to increase the volume. There's a building point here. Okay, that is a very important concept. As we increase the volume of the thoracic cavity, right? There's a principle here that we'll talk about that is hugely important. Okay, we'll get to Boyle's law in a moment. All right, the muscles of expiration, all right, are going to include a lot of these muscles that are going to pull the rib cage down. All right, help to make you more narrower, pulls the ribs more medially, and helps to pull the sternum and the anterior portion of the ribs more posterior. Okay, so it helps to compress everything. So the internal intercostals, the abdominal muscles, all right, which include transversus abdominis, all right, and the external obliques. We talked about that in lab, and then our serratus posterior inferior. Okay, all of these are going to be needed during our forced, all right, exhale. Okay, so they're going to pull everything in. So back to this picture right here, real quick. Okay. All right. So here you can see, all right, some of the internal intercostal muscles. So they're going to pull the ribs downwards. Okay. Then you can see you've got transversus abdominis and the external oblique help to pull the ribs down because of their attachment points and the lower inferior portion of the ribs here. And then serratus posterior inferior here will help to pull these lower ribs inwards and downwards, kind of compressing everything. Okay, so just keep in mind, all right, easy to remember because when you have to force anything, inspiration or expiration, we have to recruit more muscles. Okay, because essentially, exhaling is a passive process in normal people. Okay, it's a passive process. All right, so the only active process or phase, all right, is going to be inhalation, inspiration, all right, and that's going to involve the diaphragm and the external intercostals. Okay, and then for exhalation, we just relax those muscles. Okay, all right. So let's talk about the whole machinery of breathing. Okay, so when we are going to be breathing, we are going to change the dimensions of the thoracic cavity. If we're changing the dimensions of the thoracic cavity, that means we're going to be changing the volume of the cavity and the pressure inside the cavity. Okay, so on that previous slide there, you saw me talk about when we change the dimensions of the cavity. When the ribs lift upward, all right, we're going to make the cavity bigger from top to bottom. And as the ribs lift outwards, like the bucket handle, we're going to make you wider. Okay, so they're going to move laterally. And then finally, we're going to make the dimensions of your chest bigger from front to back. That's anterior, posteriorly. Okay? So when we deal with the vertical component, that's simple. Remember what I showed you here. Here's your thoracic cavity. Whoops. Hold on. Don't pay attention to that one. Here's your thoracic cavity when the diaphragm is at rest. It's a dome. So the distance from here to here, all right, is that. But then when you take a breath in, it flattens out, and now you can see there's a bigger distance. So when you take a breath in, the diaphragm flattens. Now our vertical distance has increased because simply from the diaphragm dropping down. Okay? So when it does that, boom. Then when you exhale, you return back to this. The diaphragm is domed and the vertical distance has decreased. Okay? That's simple. All right, so the thoracic cavity, all right, that's just from the diaphragm. All right, now also keep in mind the external intercostal muscles are going to lift the ribs upwards. As they do so, they lift them out like that bucket handle. So that spreads you out laterally and anterior posteriorly, also known as A to P. All right, if you hear me say A to P, sometimes I slip into that nomenclature there. It just means anterior to posterior. And if I say P to A, that means posterior to anterior. Okay? Okay, so here's a quick picture to show you kind of what we're talking about here. All right, so here, all right, when you take a breath in, okay, you can see that the height of the thoracic cavity increases because mainly what I just said, the diaphragm drops down, the ribs lift laterally away, so it gets wider. All right, and then your chest expands from front to back, and so it goes deeper. So this box is just representing, here's your thoracic cavity when you take a breath in, it's bigger. Here's your thoracic cavity as you take a breath out, as you're relaxing everything resumes back to its normal size. Here's the diaphragm dropping down, all right, or as it's contracting, it drops down. Then when it's relaxing, it's got this dome-like configuration. Your lateral dimensions of the thoracic cavity changes, it gets wider because the ribs move out like a bucket handle. Then when you relax through exhalation, it drops back down. A to P, anterior to posterior, all right, you can see here where the base of the xiphoid process of the sternum swings forward, all right, it moves forward, making the distance, all right, from the sternum back towards the spine, all right, larger than when you're relaxed. Okay. All right. I'm building up. I'm getting to Boyle's law here. We're getting there. We're getting there. Okay. So just to put in words what I just described, we're dealing with the lateral dimensions. All right. The ribs elevate. Okay. And then during inspiration, during expiration, they fall back down to the original position. All right, during elevation, we widen the thoracic cavity. During expiration, it returns back to its narrow dimensions there. Okay, and all of this has to do with, all right, relaxation following contraction of the muscles. And then our A to P, or the anterior to posterior dimension there, again, all right, when we're talking about the xiphoid process of the sternum, it swings anteriorly when you're taking a breath in, okay? Then it relaxes and it moves posteriorly during expiration. This seems like a good time to take a drink. All right, questions so far about anything that I've talked about? Nothing? Does it seem pretty basic? Okay, good. All right, if I need to move faster, I can. Again, I look at your faces, but it's hard for me to see if there's confusion or if it's just boredom. I don't know, all right? Hard to see with the masks on. All right, so, drum roll, Boyle's law. Okay, all of this is based upon, when we talk about volume changes and pressure changes, is based on Boyle's gas law, okay? And that has to do with the most important concept off of this slide is right here at the bottom. Inverse relationship between gas pressure and volume. So we know that, all right? If you don't have to be a mathematical genius, because you talked about it when you were learning about an inverse relationship between, perfect example, pH scale values and hydrogen ion concentration. All right, if you don't want to go to chemistry, let's make it a little bit easier and go to chapter 9 when you talk about articulations. All right, when you learned about the concept that as you increase stability of a joint, you decrease the mobility of a joint, or vice versa. Increase the mobility of a joint, right? You decrease the stability of the joint. So the whole point about that is that inverse relationship means if you increase one, you decrease the other. Okay, so if we increase the volume of our thoracic cavity, then we're going to decrease the pressure inside that cavity. That's the walkaway point here. And as we then decrease the volume inside the cavity, then we're going to increase the pressure. That's a very important concept. Please put that in your brain pan here, okay? So when we're dealing with the constant pressure or temperature aside, all right, we're going to assume, all right, that the temperature is going to remain constant at all times anyways for our scenarios, okay? So as we see the pressure of a gas, all right, it will decrease, all right, as you can see here in our little container over here, the pressure of the gas will decrease if the volume increases. And then vice versa, all right? If the volume decreases, then the pressure will increase. Okay? So that's basically what we're talking about. The concept that I want you to roll away with is this right here. Increase the thoracic cavity volume, you decrease the thoracic cavity pressure. Okay? Okay, so we're dealing with pressures now. So that means we have to deal with pressure gradients. Okay? Which means we're dealing with areas of high pressure and low pressure. So that's what this next slide kind of shows here. Okay? So basically you can read all this stuff, but the point being is when we talk about air pressure gradients is when one area is greater and one area is less. Okay? That's what we're talking about. If you want to get into force per unit, that's fine. But the point being is you're going to have greater air pressure in one area and less in the other. So what does that mean? Air will then move, all right, from the area of high pressure to low pressure until equilibrium has been reached. And that's what these pictures here are showing us. Okay? This one here is showing us where you have equal amount of air pressure because the volumes are the same. Okay? This diagram here shows us that the volume is greater in this area than it is here. So therefore, this area has a greater volume. That means it has less pressure. So air is going to move from area A to area B. And then this one here shows us that area A has a larger volume, or we can say area B has a smaller volume, right? Therefore, it has a higher pressure. So the air is going to flow from area B to area A. Y'all see that? Okay, this is very important because when we get to breathing, we are going to, I just talked about it for the last 20 minutes. All right, when we're breathing, when you're taking a breath in, you're changing the thoracic cavity dimensions. You're making the thoracic cavity volume larger. So therefore, that means that we're going to make the pressure inside, all right, of your thoracic cavity less. And guess what? We're going to make it less than the pressure of air in this room. So what does that mean? That air is going to flow from an area of greater pressure to lower pressure. So if the pressure in this room is greater than the pressure inside of our lungs, where does air want to go? Anyone? Greater pressure in this room, less pressure in our lungs. Where does air want to go? Into the lungs. Okay, it's going to go down that concentration, or excuse me, that pressure gradient. Okay, it's going to move from an area of greater pressure to lower pressure. Volume is going to determine, all right, where there is more pressure or where there's less pressure. Now, I can't change the volume. Well, I can. I mean, I can take us all outside, and then we're going to be in a larger area. All right, but the volume in this room is going to be our atmospheric pressure. Okay, so the only thing that really is going to change in this scenario is the volume of my chest cavity. I can make it big by taking a deep breath in and expanding everything in all directions and raising my ribs up. Okay, and then I can return it back to its normal size. Okay? So that's what we're going to talk about here when we get into the mechanics of breathing. All right? This is where we start to get into volumes and pressures during our breathing process here. Okay? So now we have to talk about a couple of terms here so you can understand what the heck that Dr. Kaz is talking about. The first one is atmospheric pressure. That's easy. That's the pressure of the air in the environment that you're in right now. So when you're in this room, this is your atmospheric pressure. When you're in your car, that's your atmospheric pressure. When you're in your house, that's your atmospheric pressure. When you're outside, going to your car, leaving class, that's your atmospheric pressure. Okay? All right, so for the most part, it is going to remain unchanged. Okay? Unchanged. So we're going to consider the atmospheric pressure a constant unless we change our altitude. Okay? So at sea level, all right, the atmospheric pressure is normally 760 millimeters of mercury. That's a constant. Okay? Now we're here in Greenville, and I think our elevation is, I don't know, 700, 900 feet above sea level. Okay? And that can change, but for right now, like I said, we're going to always consider atmospheric pressure to be unchanging. Now, if I climb Mount Everest, all right, where I'm over 26,000 feet, all right, the atmospheric pressure will be much less up there, okay? And that's where you hear the term, the air is thin, all right? It's thinner air, okay? So yes, that means if it's thinner air, then we have a lower pressure. But for our purposes, okay, assume that the atmospheric pressure, all right, if you get a test question, all right, and it asks what the atmospheric pressure, it's always 760 millimeters of mercury, okay? So constant, will not change. All right, now let's talk about stuff that will change. Okay, let's talk about the volume of the alveoli. Okay, the volume of the alveoli, all right, is going to determine or help. Remember this term before? The intrapulmonary pressure. This is going to be the pressure inside the lungs, or specifically the pressure inside the alveoli, which are pretty much our lungs. Okay, so the volume of whatever the alveoli are doing, okay, is going to help determine the intrapulmonary pressure. Okay, so this will change because as you take a deep breath in, I shouldn't even say a deep breath, excuse me, as you take a breath in, the alveoli inflate like a balloon. Okay, so they get bigger. Okay, and then when you exhale, they return back to their original shape, and so their volume gets smaller. So their volume will change, so will the pressure. It will fluctuate. Okay. So we're going to talk about all these scenarios here in which that will happen. So the intrapulmonary pressure can either be higher than the atmospheric pressure, it can be lower, or it can be equal to. And depending on what that is, all right, that pressure compared to the atmospheric pressure is going to determine which direction air goes in. Okay, so let me go back to that question I asked you before. If the pressure in your lungs is less than the air pressure in this room, where does air want to go? Into your lungs, right? Okay. If the pressure in your lungs is greater than the pressure inside this room, where does air want to go? Out. Out. I think this is the sign language for out. All right, it's going to leave. Okay, if you know that, that's awesome, because then we don't have to worry. Okay, so this last part here, that the pressure inside your lungs, the intrapulmonary pressure, is going to be the same as the atmospheric pressure, okay, at the end of inspiration, at the end of expiration. So when I breathe in, all right, it's the same as the atmospheric pressure. When I exhale and breathe out, it's going to be the same. They're going to be equal, okay? So the pressure inside my lungs, the pressure outside my lungs will be equal at the end of taking a breath in and at the end of exhaling that breath, okay? And you'll see it when we go through some more of the material here. Okay, so there's the atmospheric pressure we talked about, the intrapulmonary pressure. Now we have the intrapleural pressure. We talked about that earlier on, okay? All right, this is the pressure inside the cavity that your lungs live in. This too changes, it varies. Okay, and it depends on what's happening. Okay, but remember, we talked about this before. All right, this pressure is going to always be lower than the intrapulmonary pressure, because we talked about that's how we keep our lungs inflated. If it gets bigger, excuse me, if it becomes greater than the intrapulmonary pressure, then it's going to push the lungs and collapse them. Okay? So intrapleural pressure has to be less than the intrapulmonary pressure. Okay? Normally, it is around 4 millimeters of mercury. It can be as high as 6 millimeters of mercury, and we'll talk about that. Okay, so this concept is huge. If you walk away with anything off this slide, it's this one here. Volume changes create pressure changes, and air flows down its pressure gradient. All right, this is where I was going with a lot of this stuff. That's that Boyle's law thing again. Okay, as we increase, I'm going to say this 100 times, and I don't care if you get annoyed with me, I don't care. All right, because that means you're listening to me. I'm hoping it's going to permeate into your brains. Okay, you increase the volume, you decrease the pressure in that area. Okay, decrease the volume, you increase the pressure in that area. Okay, so the only thing that we can affect the volume of is going to be the thoracic cavity. It's the only thing in all of these concepts here. So when we take a breath in, the thoracic volume increases. That means the pressure inside the thoracic cavity, the intrapulmonary pressure, decreases. And so air goes in. Okay? When you exhale, all right, and your muscles all relax, okay, that thoracic volume decreases back to its original size. All right, the thoracic pressure increases and air goes out. I got pictures. I'll show you pictures so you can see this. So you can see numbers. If you're a numbers person, cool. If you're not, I got pictures. Okay? Okay. So here you can see in our drawing here, okay, let's look at some numbers and some values here. Okay, atmospheric pressure. Remember, we always said this is going to be constant. It's always going to be 760 millimeters of mercury. 760. Okay, put that in. So that's the pressure that's out here in this room that this person is going to breathe. Okay, so this person just got done exhaling. Okay, remember what I said? The atmospheric pressure and the pressure, the intrapulmonary pressure, are going to be equal at the end of inspiration and at the end of exhalation. So this person just breathed out. Their atmospheric pressure is always going to be 760. Their intrapulmonary pressure is 760. So if the pressures are equal, is there going to be any movement of air at all? No. Good. Yes. Yes. All right. Cool. So let's look at some of our other values here. All right. So we're looking here now at the pleural cavity, and its pressure value is 756. That's a difference of 4. Remember, the pleural cavity has to be less than the intrapulmonary pressure. Okay, otherwise it would collapse the lung. Okay, this is how we keep the lungs inflated, right? Because we're pushing out. Okay, so this number here always has to, I got too many lines up there. All right, this value, all right, this always has to be less than this value here. Less. Okay, if it becomes greater, we're going to collapse the lung. Cool? Okay, cool. Okay, so now we're going to talk about what happens when you take a breath in. I told you I'm going to go through steps. You're going to get bored of me. That's fine. Okay, that means you know what I'm talking about. Okay, so let's start off. Regular breathing, as we're all doing here. Breathing in, breathing out. All right, as we're taking notes and listening to Dr. Kaz. Okay, so we just exhaled. Okay, we're about to take a breath in. Remember, okay, our intrapulmonary pressure and the atmospheric pressure are equal. Okay, don't forget, intrapleural pressure still going to be less. 756. It's going to be less. Okay, so what happens? You're going to take a breath in. Diaphragm contracts, it flattens out. Okay, the external intercostals contract and elevate the ribs. So all the dimensions of the thoracic cavity start to increase. The volume of the thoracic cavity grows. Okay, as it does so, all right, we're going to see a decrease in the intrapleural pressure. We'll get into that in a second. Okay, but as this happens, all right, the lungs are going to expand outward. So we increase the overall lung volume. As we increase the lung volume, remember our inverse ratio, our inverse relationship, as the volume of the lungs increases, as the volume of the alveoli increase, the pressure inside the alveoli decrease. What do we call that pressure? The intrapulmonary pressure. It drops down. Okay? And because that intrapulmonary pressure has decreased, all right, below the atmospheric pressure, air flows in. And the amount of air that flows in is typically half of a liter, 500 milliliters, okay, 0.5 liters. We refer to that as tidal volume. You'll learn this later on. We'll talk about tidal volume and all that other stuff. But for right now, normally on a normal breath, for all of us, I don't care if you're big, small, whatever, okay, it's going to be 500 milliliters of air is going to enter into your alveoli, okay? 500. Should know that number. Tidal volume, 500 milliliters. Are we good so far? If I swear to you, if nobody feels good on this, I can walk you through it again, okay? I don't want to bore you too much, okay? Just keep in mind, keep it simple. Increase the volume, we decrease the pressure. Air is going to go from an area of high pressure to low pressure, okay? So our atmospheric pressure stays constant, will not change. Always 760 millimeters of mercury, okay? But the volume inside of our thoracic cavity will change. It will fluctuate depending on whether you're breathing, inhaling or exhaling, okay? All right. Let me show you that on picture-wise on this first slide, then I'll go to the exhaling. Okay, so here again, we just started. We haven't started breathing yet here, all right? So everything's good, all right? Atmospheric pressure, 760. All right, intrapulmonary pressure, pressure inside the lungs, 760. Equal. No air is moving. Okay, now look at the diaphragm. See this little dome there? Now we're going to take a breath in, and you can see, look at the blue area on this part, and then look at it here. It's huge. The blue here is bigger, the blue not so big here. Okay? And look, the diaphragm's domed here, now it's flat. So we've increased the volume here of the thoracic cavity. Okay? And by doing so, we've decreased the pressure inside by just 1 millimeter of mercury. 759 millimeters of mercury of pressure inside the lungs, and the intrapulmonary pressure, that's its value. And then our atmospheric pressure is still the same, so air goes in. Okay? And that's roughly going to be about 500 milliliters. Now, if you look here, all right, our intrapleural pressure is going to be 756. All right, as you take a breath in, it drops down to 754. It's still less. It's still less than this number here. So our lungs don't collapse. Okay? But it did drop down. Okay? So the pleural cavity, all right, and I didn't talk about this, but if you look, all right, the pleural cavity has also increased in size. All right, if you look at the volume here, you can see here's the pleural cavity right here, this blue area. Okay, and you can see there's a larger pleural cavity exposed during the breath in. And so that cavity is also increased in volume, so therefore the pleural pressure drops down. Okay, keep that in mind. Boyle's law, Boyle's law. Okay, increased volume, decreased pressure, and vice versa. Okay, so now let's talk about breathing out. Okay, so at the end, okay, at the end of our breath in, remember what I said, okay? The atmospheric pressure will equal the intrapulmonary pressure, okay? So at the end, it's 760. I'll show you here in our little drawing here. Okay, atmospheric pressure is 760. It's 760 here inside at the end of taking a breath in. So that's no more air is moving again. Okay, so no more air is entering in. Now it's time to relax everything and have air leave. Okay, and that's what we're going to talk about here. Okay, so we're going to start off with equal pressures. Equal pressures. In this case, though, now instead of the difference being 4 millimeters of mercury, now it's 6. Because the intrapleural volume has increased also. Okay? So now the diaphragm relaxes, the external intercostals relax, they go back to their original position, they drop the ribs down, all right, the diaphragm goes back into its domed configuration there, decreasing the volume of the pleural cavity. Okay? Decreases the volume. So if we decrease the volume, what are we going to do to the pressure? Increase the pressure. Boom. So now, all right, we see the pleural cavity volume decreases, intrapleural pressure will now increase, okay, and we'll also see, all right, the alveolar volume decrease, because remember, the air sacs are now deflating a little bit, okay, that allows the intrapulmonary pressure to increase. And don't forget, we have all the elastic there, and that's going to help to pull the lungs back to their original shape. Okay, those elastic fibers that are laid all over the alveoli, okay, help to shrink the alveoli back down. Almost helps to push air out a little bit, okay? And so, since the intrapulmonary pressure is now greater than our atmospheric pressure, where does air go? It goes out. It goes out. And what comes up must go down, and what comes in must go out. So we breathe out the same amount, 500 milliliters, okay? Even exchange, even exchange. Normal breathing, okay, what we're doing now. 500 in, 500 out. Good so far? If you guys are picking up on this, you're going to crush this chapter. I'm telling you. I'm telling you, I love it. You guys are going to get me excited. I might even drink some more water. Okay. So that's what this drawing is showing us. Okay, so at the end of inspiration, you're looking like this. Your lungs are inflated, the cavities are nice and big. All right, we've equalized the pressure, all right, inside the lungs compared to outside the lungs. Then it's time to now relax everything. Okay, so as we do, the diaphragm goes back to its original configuration. All right, the ribs shrink down, and thereby we've shrunk the pleural cavity. All right, and the alveoli have all decreased in volume. So decrease the volume, increase the pressure. So we see that the intrapleural pressure increases back to 756. But in this situation, all right, the intrapulmonary pressure has now increased to 761, which is greater than atmospheric pressure. So our air will now leave, because the pressure outside is less than the pressure inside. I really like this picture, okay? It helps to explain. So I would say, what is that, figure 23, 22A? Look at it. Memorize these numbers here and what it says here, what's happening, all right? If you understand, you don't have to memorize it if you understand the concept. I think if you understand Boyle's law, then it'll just make sense. You got to kind of think through it. But if you want to access the information a little bit quicker, then just memorize it, okay? But understand it, okay? It's all about pressure changes, like we saw in the heart, okay? When the pressure was greater inside of the atrium than it was in the ventricle, then the blood would flow from the atrium to the ventricle, okay? It goes from an area of high pressure to low pressure. That's what we're going to see here, okay? And so you can see on these pressure curves here, and it's comparing, all right, both the pressures within the lungs here, all right, when you're taking a breath in, you can see the volume of the lung increase over time, right? And then as you exhale, all right, the volume decreases. Inhale, exhale, about 5 seconds, okay? So that's right, roughly about 12 breaths a minute, okay? But you can see here, all right, the pressure, and if you look here, check it out. As the volume of the thoracic cavity increases, you can see both of these pressures for the intrapulmonary and the intrapleural, they both drop. Well, that makes sense. That's Boyle's law right there. Okay, increase the volume, decrease the pressure in both of them. Okay, now we can see, all right, when we start to exhale, the volume starts to drop off. But look, you can start to see, all right, the pressure starts to increase. Okay, starts to increase, starts to increase. Okay, that's what we're looking at. Okay, Boyle's law. So for the first part of this chapter, Boyle's law. Okay, answers everything. Ask me a question, anything, I'm going to tell people. I'm going to do that for a day. So ask me a question, Boyle's law. Boyle's law. They'll be like, what the heck are you talking about? All right. So what about forced breathing? Okay, it's nice. It's similar to quiet breathing, but obviously we're going to recruit extra muscles. Okay, because remember, our goal is we have to change the thoracic cavity volume. We've got to change the volume of our rib cage. We got to elevate those ribs. All right, we got to get that diaphragm's going to drop down. Okay, so we need to make sure that intrapulmonary pressure, all right, can accommodate those thoracic cavity volume changes here. Okay. So and in order to do that, we just need more help, more work from those other muscles that are going to be involved. Okay? It's all based on, I won't say the supply and demand, but I mean, obviously, as the demand for your systemic tissues increases, depending on what type of activity you may be doing, exercising, running, working outside or whatever, your breathing rate's going to increase so you can get more air. All right, that tidal volume of 500 milliliters. All right, normally you can get 12 breaths in a minute during normal breathing. Okay, well, your respiration rate can increase up to 22, 25 breaths, probably even more, depending on how much you need to occur. All right, so we're going to recruit some of these muscles here to move more air in and out of the lungs. Okay, so that's going to create some really significant volume changes in the thoracic cavity. All right, good so far? Man, we're cruising, y'all. Do you feel like this chapter is a little bit easier than immunology? Yeah, I know. I felt like too. Once you understand the concepts, it makes a little bit more sense. All right, so let's talk about flow. I'm not talking about the lady from Progressive. I'm talking about, all right, airflow. Okay, and so now we're going to start talking about how much air moves in and out. Okay, similar to blood flow in regards that there's going to be a pressure gradient involved and resistance. So obviously, when we're talking about airflow, we're going to be discussing the pressure gradient. All right, and the two places are going to be, remember, in the circulatory system, we talked about the pressure gradient between, all right, the arterial area of your circulatory system versus the venous region, like the vena cava, the superior and inferior vena cava, and the aorta were going to be your pressure gradients. Well, here we're going to determine it between atmospheric pressure, the pressure outside of your body, and then the pressure inside your body, intrapulmonary pressure. Okay, that's easy because we just talked about that for the past 10 minutes. And then resistance. Okay, so we have to think of all the places in which air can be resisted from when it enters your body down to the lungs. Okay, so that's going to include all your airways, nose, mouth, trachea, bronchioles, down to the lungs. All right, we're going to talk about the lungs and then the chest wall. Okay, because remember, chest wall is important because that's how we change the volume. So we have to manipulate the chest wall somehow. All right, so resistance is going to play a role there. So airflow, pressure gradient, and resistance. All right, so there's an equation for that we'll talk about here. All right, but first of all, I do want to move on. All right, we're going to come back to this in a moment. I thought I had that. No, okay. We'll come back to that. I was just going to hit you with an equation, but I'm going to wait. All right. So let's talk about how you as a human being, all right, and your control center, which is the central nervous system in this case, how the control center is going to affect, all right, how you breathe. Okay. You heard me talk about the medulla oblongata. Okay. Primarily, the brainstem is going to be the region of your brain that is going to control, all right, your breathing. All right. So it's going to be in the medulla oblongata and in the pons. Okay. So you have two respiratory centers. The primary one is going to be in the medulla oblongata. Okay. All right. So it has two different groups: the ventral respiratory group and the dorsal respiratory group, VRG, DRG. All right. And you're going to see both of those, all right, in the medulla. And then the pontine respiratory center is going to be in the part of the brainstem that sits on top of the medulla oblongata, and that's going to be the pons. Okay. All right. So let's talk about these breathing areas and what areas that they're going to affect. First of all, this is going to require you to go back and dig down into your knowledge from 210. All right, in regards to upper and lower motor neurons, if you remember that, okay, when we're talking about the motor component of your nervous system, you have an upper motor neuron, which is seen pretty much predominantly in the central nervous system, and the lower motor neuron, which is going to be seen in the peripheral nervous system. Okay, so when you hear me say upper motor neuron, all right, you should be thinking all the way up from the brain to the spinal cord, and then from the spinal cord out to whatever the effector organ is, you should be thinking lower motor neuron. Okay, so in this case here, all right, when we're talking about the brainstem, all right, from the ventral respiratory group, all right, it's going to send neurons all the way down, all right, to the spinal cord. And then from the spinal cord, the motor neurons that are leaving the spinal cord out to those skeletal respiratory muscles, all right, are going to venture on the lower motor neuron. Okay, so there's going to be two types. All right, we've got our phrenic nerve, which innervates our diaphragm. Okay, no, C3, C4, and C5. Those spinal nerves contribute, all right, to the phrenic nerve and helps to innervate the diaphragm. Okay, and then we have our intercostal nerves, which are going to innervate the intercostal muscles. Okay, and the intercostal nerves are the anterior rami, okay, of your specific thoracic and cervical spinal nerves. Okay. Okay. So basically, all that meaning, you have neurons that are going to travel from your brainstem down the spinal cord. They're going to synapse on another set of nerves that are going to then go from the spinal cord out to the effector organs. And in this case, our effector organs are going to be the skeletal muscle of the diaphragm and the skeletal muscle of our intercostal muscles. Okay? If it goes to the diaphragm, we're dealing with the phrenic nerves. If we're going to the intercostal muscles, we're dealing with the intercostal nerves. Okay. So there's a lot of components that help to monitor your breathing rate. Okay, so again, going back to chapter 1, right, we learned about homeostasis and that homeostasis system, how we have receptors, control center, and effectors. So we're going to start off with the receptors because they're going to be, all right, the items that are going to be monitoring stimuli and sending that information to our control center, which is our central nervous system in this case. So some of the receptors that we are going to be discussing are chemoreceptors. And you remember chemoreceptors from chapter 16 when we talked about that these are specialized receptors that are going to monitor the chemical concentration of certain molecules. Okay? In this case, we will deal with the partial pressure gases of carbon dioxide and oxygen. All right, those are our respiratory gases. But remember this? hydrogen ions, pH, okay, acids and bases, okay. So when you see H+, you should start thinking of acids and bases, and then you should start thinking of the pH scale. Okay, this is another one of those inverse relationships that you learn in Chapter 2. Okay, hydrogen ion concentration. If you have a lot of hydrogen ions, you're going to have something that has a low pH, and that means it's acidic. Okay, if you have something that has very little hydrogen ions in it, okay, then that means it's going to have a high pH and it's basic. Can anyone tell me, is it written up there? No, good, it's not. Can anyone tell me what the normal pH value of your blood is supposed to be? Anybody? If anyone is still paying attention at home, feel free to type your answer in. All right, it's a scale, all right, but there's a specific value. You need to know this, and you will. You'll have to know it for this course. We just haven't really touched on it. All right, the value is going to be 7.4. All right. And so basically anything between 7.35 to 7.45. All right, just normally that's the set point, 7.4. You need to know that value. That's what we want the pH value of your blood to be. Okay, slightly basic. Okay, so anyways, these chemoreceptors are going to monitor the concentration, all right, of hydrogen ions and then your carbon dioxide levels and your oxygen levels. Okay, and so there's two types. There's those that are going to be, all right, that are going to be in the central nervous system. So we call those central chemoreceptors, and they're going to monitor the cerebral spinal fluid. Okay, make sure that's hunky-dory. Okay, because basically cerebral spinal fluid is just filtered out blood plasma. All right, there's a little bit more to it, but it's very similar to the makeup of blood plasma. Okay, so again, we're going to check out, make sure that it's not too acidic or too basic. Okay, so we're also going to then have our peripheral chemoreceptors. All right, and they're going to be located, all right, in the arch of the aorta and also in the common carotid. Okay, and so it's going to monitor the concentration levels of hydrogen ion molecules and respiratory gases. Okay, now we're going to learn all about all this stuff later on. Okay, if you want to write that down, you can. Carbon dioxide diffuses from the blood to the central cerebral spinal fluid, where carbonic anhydride is located. And basically, we're going to see how we build up carbonic acid. We'll talk about that whole process later on. If you want to write that down, feel free. Okay, but that's when we start to get into the buffering system. All right, remember we learned about acids and bases, and we talked about neutralization and buffering and the importance of that. All right, neutralization is when you have something that's too acidic, you add base to it, and then it becomes neutral. Okay, when we're dealing with buffering, we're trying to prevent that change from ever occurring. Okay, so if things start to swing and become a little bit more acidic, all right, then we have these chemical processes that the body has, which will try to swing it back to being, all right, more neutral or make it more basic. Okay, so we'll talk all about that. But for right now, I want you to know that our central chemoreceptors are going to deal with the pH in the cerebral spinal fluid. Okay, yes, that involves the partial pressure of carbon dioxide, only because it's going to undergo, all right, some chemical reactions, all right, and form carbonic acid, all right, and carbon dioxide. We'll talk all about that later on. Peripheral chemoreceptors, all right, are going to monitor hydrogen ion concentrations, all right, in the blood and the respiratory gases in the blood. Okay. So when we're dealing with the carotid chemoreceptors, you need to know this, that information travels on cranial nerve number 9, glossopharyngeal. And we're dealing with the aortic chemoreceptors, all right, that information is going to travel to the respiratory center via my favorite nerve, cranial nerve 10, vagus nerve. Okay, vagus nerve is another nerve that you will want to answer if you have no idea what the answer is to a question. And if it lists which cranial nerve is responsible for whatever, and you have no idea, answer vagus nerve. Okay, vagus nerve does a lot. It sees a lot because it's done a lot. Okay, so guess what? I think Ooh, I want to do more talking, but I'm going to stop here. Take a break. Okay, let's take a quick break, and then we'll pick up from where we left off here.